Professor Helmi Abaza, Professor Nahid Badur to chair ASTRA Symposium. Dr. حلمي
ايوه معاك.
يلا اتفضل، انت معاك ASTRA Symposium دلوقتي.
طبعا يهمنا ان يكون معانا الاستاذ الدكتور شريف بجاور from Cairo University، طبعا well known figure in the field of gastroenterology pathology. هيكلمنا على H. pylori updates. اتفضل استاذ شريف.
Good evening, everybody. It's my pleasure to be with you today in this very successful conference. I thank Professor Yusri for the invitation, Professor Helmi, and it's my honor to speak here with our chairers, Professor Helmi, Professor Yusri, Professor Nahid Badur. And in the coming few minutes, I'll be talking on H. pylori updates. And I'll present part of my talk telling you about already what we know from H. pylori. And then I'll go through some updates by answering 10 questions. Hopefully they will help in updating our information on H. pylori. We already know a lot about H. pylori, and we know that the past has changed. When we used to see these deep ulcers in our routine endoscopy, and at the time when surgeons had a role in managing and treating peptic ulcers surgically, things have changed a lot since the discovery of proton pump inhibitors since the late 80s and early 90s. And of course, after the discovery by Warren and Marshall of the H. pylori, we have been seeing the present so much different than the past. Less severe forms of peptic disease and better eradication and the power to eradicate our ulcers, better healing, less recurrence and lesser malignancy. We still know that the challenge exists because we know that we cannot cure all cases. Malignancy is still a challenge, and the reason is because there is a point of no return. This is the point when the patient reaches a level when he has atrophy or he has metaplasia or dysplasia. At that phase, even if we eradicate H. pylori, we still cannot decrease the risk of malignancy. H. pylori is well known for us, and it was identified since 1874. And then it was named as H. pylori as Helicobacter since 1989. It can produce any upper GI symptoms, and it's characteristic as a gram-negative organism producing exotoxins and enzymes. We have to know that it's transmitted mainly fecal-orally. However, gastric oral and transmission from water and oral and from animals is also possible. The most important information that the gastritis developed as a result of interaction between host genetic factor, the virulence of the organism, as well as the host immune response. But we have also to know that at the end of the day, it's chronic gastritis which we care. And not all types of chronic gastritis, it's only the gastritis which occurs in 5%, which is the corpus predominant atrophic or the multifocal atrophic gastritis. This type of gastritis, which may be in 40% transform into intestinal metaplasia, from this 8% may pass to dysplasia and only 2% go to gastric cancer. So this is the only percent of patients we really have the risk of malignancy in, and the risk of malignancy is really seems to be low. We know quite well also that we should not test empirically for H. pylori. We test if we know that the patient has a history of peptic ulcer disease, malt lymphoma, gastric cancer. If a patient is under 60 and he has dyspepsia without alarm symptoms, if a patient has dyspepsia and is investigated by an upper endoscopy, patients receiving medications such as aspirin or non-steroidal anti-inflammatory drugs, as well as patients presenting with idiopathic thrombocytopenic purpura or unexplained iron deficiency anemia. These are the patients we recommend to test for H. pylori. Now, H. pylori is not a gastric disease only. It seems that it also has an extra gastric part, which is really developing year by year. And we are learning more and more diseases which really prove to be related to H. pylori, such as the iron deficiency anemia, idiopathic thrombocytopenic purpura, urticaria, some skin diseases, as well as other disorders related to cardiovascular, neurological, as well as chest disorders. Most are not 100% proven, but really there are a lot of studies which correlate the H. pylori to diseases in different parts of the body. Cancer stomach stands number 4 in incidence and in mortality worldwide. And I think it's the same in Egypt. The incidence in Egypt is from 4 to 5%, for 4 to 5 per 100,000 population. So you see, it exists, but it's not one of these risky malignancies. And every study, whether recent or old, have favored to eradicate H. pylori in order to lower the risk of malignancy. Unfortunately, the bad part of news is that if we reach this point, which is the point of no return, it's the point when the patient has already developed the atrophic gastritis, metaplasia, or dysplasia. If we try to eradicate H. pylori, we do not succeed in decreasing the risk of malignancy. So it's a window of opportunity. We have really to deal with the H. pylori during this window. There are a lot of updates on the management of H. pylori infection. Data is pouring every year. Things are really changing. But the bad news is that even the most respectable guidelines, whether this of the American College of Gastroenterology, Toronto guidelines, Maastricht guidelines, all of these, they may be consistent in most of their decisions, but in some cases, you find them inconsistent. For example, in the concomitant non-bismuth quadruple therapy, you find them, for example, ACG, it recommends them if bismuth quadruple therapy fails. Toronto says that there is not enough data. Maastricht says you can if bismuth quadruple fails and levofloxacin fails, and then you are in an area of low resistance to clarithromycin. So they are really not consistent in most of the cases. And in Egypt, it's much more difficult. Why? Because we don't have local guidelines. And of course, the regional drug resistance is not available in most cases. We don't have drug resistance tests available in most of our labs. Bismuth preparation is expensive, and most of the time it's not available. And of course, in many cases, we neglect retesting our patients. This makes it really difficult, and we need the strength to update our information and also to tailor the updates according to our situation in order to improve our patients' care and develop better outcomes during management of H. pylori. Hope the coming questions will help. The first question is, which cure rate of H. pylori infection is considered sufficient worldwide? Here comes the Kyoto Global Consensus telling us, if you don't have a regimen which eradicates H. pylori in a percent more than 90%, then you should not use this protocol. And also from this review, they conclude that a reliable protocol should have an eradication rate more than 90%. So I can easily reach my first recommendation that eradication treatment for H. pylori must achieve more than 90% rate of eradication. If I don't have this rate, then I'm not successful in managing most of the cases of H. pylori chronic gastritis. So the question number 2 comes, how efficient is standard triple therapy in H. pylori eradication in your region? And I find it difficult to answer this question in our region because we really don't have sufficient statistical data to answer the question. And I can give you some data from Europe, and it shows that until the year 2018, and this is updated more recently, but they still show that the triple therapy is used in more than 50% of cases, even more than concomitant therapy, sequential therapy, and bismuth therapy. Although there is quite definite data from Europe telling us that they have resistance considerably to metronidazole, clarithromycin, and levofloxacin. But the bright part of the story is that there is almost minimal resistance to amoxicillin, tetracycline, and rifabutin, which I think we will have soon in our market. So antibiotic resistance testing, unfortunately, is not widely available among our laboratories. And there is insufficient resistance and susceptibility data in various geographical areas among our country. Treatment selection for this reason is rendered empiric. And we should realize that when we tailor our regimens, we have to use those antibiotics which are known to have the lowest possibility of resistance, such as amoxicillin, tetracycline, and rifabutin. And for the reason of using the triple therapy most of the time, you can see that the results are around 70%. This is a non-satisfactory result. The first recommendation that if we have a cure rate less than 90%, this is not a satisfactory outcome. Maastricht comes definitely telling us that you have to stop using clarithromycin in areas where the resistance is in more than 15% of your population, and you should substitute this by any other protocol of 14 days, whether hybrid reverse or hybrid concomitant therapy or bismuth quadruple therapy, also in case there is resistance to clarithromycin. Recommendation number 2, it states that the efficacy of the standard triple therapy is clearly suboptimal. Therefore, we should stop using this and we should resort to the quadruple regimens, and we should tailor our antibiotics according to our available experience and anecdotal and observational results. What would be the ideal duration of treatment of H. pylori? All of us know, of course, the answer. All of the reviews have stated whatever regimen you're using, concomitant, bismuth quadruple, or any other regimen, it should never be less than 14 days. Maastricht also states that you have to use any regimen for at least 14 days. And if you want to use it for 10 days, you have to be backed by sufficient data, sufficient studies telling you that this regimen is really successful in more than 90% of cases when you use it for only 10 days. The Toronto consensus confirms this. It's also 14 days. So I can easily reach the recommendation number 3, that eradication therapy should be prescribed for 14 days unless we have studies telling us that in certain regions we can use a lesser duration. What's the ideal proton pump dose in regimens of H. pylori eradication? A very important question here. What's this ideal dose? Most of the reviews and articles recommend doubling the dose of the proton pump. And this has been postulated since a long time in rescue therapies, and there are really scarce trials in this point. Yet, most of the reviews and articles recommend the double dose. Studies tell us that if we use the first generation or second generation proton pumps, doubling the dose will really favor a better response. And if you use the triple therapy and double the dose, you may achieve much better results. So doubling the dose seems to be very sufficient in order to reach a better outcome. And for this reason, this very respectable text has stated that if you want to reach a reasonable 90% at least significant improvement and significant cure rate, then you have to double the dose of the proton pump. And esomeprazole was found to have this fast suppressing effect, reaching a good response within the first 4 hours. And also this was maintained for almost 70% of the time all through the day, which is really much better when compared with many other of the proton pumps. Vonoprazan, unfortunately, is not present in Egypt. It works as an hydrogen potassium ATPase inhibitor. This really will have a very important role in eradication of H. pylori once it is available, since it has a very powerful suppressing effect on the pH. The recommendation number 4, that we use a high dose of proton pump in H. pylori, should be highly recommended and emphasized. What about bismuth? And we know that we don't have bismuth most of the time, and it's an expensive, the molecule itself is not expensive, but the drug which contains bismuth is an expensive one. So how does it work, and what does it add to the treatment? In this article, we have quite strong evidence that adding business to any protocol will increase the efficacy at least 25%. And in this review, they also find bismuth quadruple therapy, because it contains bismuth, a very powerful drug in eradication of H. pylori. And also in this review, any protocol containing bismuth was recommended because of the high efficacy and the cure rate, which is more than 90%. So the fifth recommendation is the efficacy of triple therapy is markedly improved by adding bismuth to the standard triple therapy, even in the presence of antibiotic resistance. So what are we going to do if the patient has penicillin allergy? What are the guidelines telling us, and how should we move further in such a situation? The problem is that the guidelines will tell you to use a bismuth-containing quadruple therapy. Unfortunately, we don't have this, but we have the Maastricht guideline telling us that this rescue treatment could be used. A fluoroquinolone-containing regimen may represent an empiric second-line rescue option in the cases of penicillin allergy. So my recommendation number 6, in patients with penicillin allergy and in regions where bismuth-based therapy is not available, triple therapy, including proton pump, Clarithro, Levo, may be recommended. What about probiotics? Which is, of course, you hear a lot about probiotics, and there are a lot of studies really, and there are a lot of articles during the last year studying the effect of probiotics on H. pylori. But really, most of these studies are inconsistent. Some of them will show some benefit, minimal benefit, a little bit better results, but most of them say that there are no significant results. And one of these studies came from Spain, where they studied 209 patients receiving lactobacilli and pedococcus, compared to a group who received the placebo, and really there were no significant result in the outcome of eradication of H. pylori. So the conclusion will be that probiotic cannot be generally recommended for eradication of H. pylori in general practice. So question number 8 would be, would you repeat the same antibiotic previously used during an ear occasion? And when should you test for susceptibility? I think that this is one of the most important questions, because we face this in our daily practice. Patients receiving antibiotics for eradication, they fail and come once and twice and thrice, and they're coming for your consultation. So usually what's recommended by guidelines and what should we do? Of course, if any patient, according to the Maastricht guidelines, coming to you using an antibiotic, which we know that has a high possibility of resistance, and of course it's clarithromycin, for example, or metronidazole, it's forbidden to reuse these drugs or these medications. And of course, we know quite well that there are other medications which are less likely to produce resistance, which we should think of. So should we think of susceptibility testing? And is it available? Unfortunately, all of us know that it's not available, but Maastricht guidelines recommend that if you are going to use a first line, then a second line, and it's time to use a third line, that's the time where you should use a susceptibility testing, and you should confirm this before shifting to a third line of therapy. Unfortunately, if you don't have this, then we have to tailor our regimen according to what we know. And what should we know is that after treatment failure, resistance to Clarithro, Metro, and quinolones approaches 100%. Please don't use these antibiotics repeatedly, and think of others who have lower resistance. Bismuth is not available, but amoxa, tetracyclines, and rifabutin, I think, will shortly be in our market. And this will give us the option to really tailor our regimens, thinking of resistant antibiotics and antibiotics which are less likely to develop resistance. So my recommendation number 8 is that clarithromycin and quinolones should not be repeated when they fail to be treated in the first time. And if we are going to shift to a third line and there is an availability to a susceptibility test, please do it. If not, then you're facing the problem of using your anecdotal self-experience and observational studies. Question number 9, for endoscopic assessment of H. pylori gastritis, what are the number of biopsies you should take? And really, we have to remember always that the Maastricht guidelines recommends 4 biopsies. 2 from the antrum and 2 from the corpus. And that from the antrum should be 3 centimeters from the pyloric ring. And from the corpus, 1 from the lesser curve and 1 from the greater curve. And please make the pathologist's life easier, and please send them 4 biopsies, not only a single or double biopsies. 4 biopsies will not take time, and you will give him a comfortable biopsy tissue sample in order to give you the result. And this is the way to do the biopsy. And 4 gastric biopsies, 2 antral and 2 from the corpus, are really mandatory in order to diagnose gastritis. Last question is, do you check for H. pylori cure after treatment? It's very important because most of the guidelines tell us it's crucial, it's mandatory to check response of the patient. Unfortunately, I don't know, for a certain reason, it's not a common trend among our patients to retest, but it's important to recommend performing either a breast test or an H. pylori antigen following treatment. And the reason for this, because the patient, if he has this treatment or if he has this infection, he will be at the risk of complications. And the test is really available, easy, simple. It's not really costly. And sometimes it's the patient preference himself to find out that he has been curing. Then test cure is the only way to measure our success to eradication. We have no way to test. It's not, the patient may keep asymptomatic and we don't know if we have cured the organism or not. It's the only way. So my take-home message is that the cure rate less than 90% is never accepted nowadays. We know quite well by now that the standard triple therapy is suboptimal in most regions worldwide. 14 days and the double dose proton pump is recommended. Third-line therapy should start after susceptibility testing, if it's available. 4 biopsies for H. pylori evaluations is mandatory. Checking for cure is highly recommended. And just before leaving you, I'd like just to tell you good news is that the FDA approves Talicia, which is a drug containing 2 drugs, 2 antibiotics, which are not known to have likelihood to resistance. It's amoxicillin and rifabutin. So by this, I think it's time to thank you all, and a special thanks to AstraZeneca to give me this opportunity. Special thanks to Yusri, Professor Yusri Tahir, Professor Helmi, and now I'm ready for any questions.
Thank you, Professor.